pleasure to be here another Wednesday in the MedStream program. Vamos a sacar esto. I'm Alfonso Jurado, one of the staff members of the team. Beside me, as usual, is Dr. Galeote, and also outside the cath lab are helping us Daniel Debar, one of our fellows, and Clara Hueto, who is going to present the case. Clara.
Hello. Well, our first case is about a 76-year-old male with medical history of atrial fibrillation, dyslipidemia, and inflammatory bowel disease. On May, he was admitted to hospital because of an STEMI. The laboratory tests and the electrocardiogram were normal. Here you can see the coronary angiogram, in which we can see a severe and calcified lesion in the anterior descendant artery with heavy calcification around. In the right coronary artery, he has another lesion in the limit of severity. Because of that, we did a pressure wire with a negative result. So we are going to do a percutaneous revascularization of the anterior descendant artery using lithotripsy to obtain the best result in the calcified lesion, and we are going to guide the procedure with an imaging technique, which is OCT.
Okay, thank you, Clara. You can see I'm going to show you the setup. We are using a radial approach with a slender sheath 7 French. And we have been struggling a little bit with the access, as you can see in the angio, because of the tortuosity at the subclavian artery. And this is the angio showing the buccal there. And we could advance with a year 4 5 French catheter and a Terumo wire and a hydrophilic one. You can see here a little bit playing with the respiration of the patient. And after that, I can show you the image. This is a very good case to show the lithotripsy technique because it's a severely calcified lesion, as you can see, just with the angio. We are doing OCT as well. And we have 3 side branches here. Guillermo and me was discussing the best way to treat it. You can see probably the bigger one is the proximal, logically, but the disease probably is worse at the ostium of the second and the third diagonal. And also after the more critical stenosis, there is an aneurysm, and we have been also discussing of covering all the lesion, including the aneurysm, or using the landing zone, just the proximal part of the aneurysm. So we have performed the OCT. We have protected the second branch and also struggling to get into it because of this funny angulation. And we have now one Sion extra support wire in the LAD and another wire in the second diagonal. As you can see in the OCT pullback, the catheter, the OCT catheter is also almost occlusive. But now the flow is perfect. Now in the OCT, you can see there the calcification is an eccentric plaque, probably, you know. Well, I don't know. It's 230 degrees, and it's very thick calcium there. You can see it, and almost circumferential at some points. So we can predilate a little bit. I would predilate the diagonal firstly. I think that seeing that the OCT catheter is occlusive, I think we have to predilate both branches, probably the LAD at the occlusive lesion, just to improve the flow a little bit, and also probably the ostium of the diagonal, the second diagonal. Can debate about the possibility of treating the second diagonal with a drug-eluting balloon. We thought that about the option of predilating a little bit before the OCT, and we try to do from the very beginning just to not be seeing the modification. Discussing about because the third diagonal is the third diagonal, not the first one, but it has also some stenosis at the ostium. And if we land the stent of the lady before this branch, it's a good option to preserve it. But the lesion that we have seen in the OCT distal to the third diagonal, I don't know, probably we need to treat it. And one advantage of this plaque modification technique is that, as you can see, you can use it through a conventional 0.14 wire. And it doesn't need a specific wire. And you can also use it by a 6 French guiding catheter and protect all the side branches you want. So this case illustrates very well some of the advantages of this technology. So you have to use a balloon sized 1:1 to the vessel diameter, and intracoronary imaging is a key point of the procedure to assure that. The preparation of the balloon is a mix of saline and contrast 50-50. So we are going to try to advance the shockwave balloon 3.0 after this slight predilatation with a 2.0. We are doing firstly this part. Another option would have been to dilate with a drug-eluting firstly the diagonal. Let's see how it works. So we are going to inflate to 4 atmospheres. And then when the balloon is inflated, 4, I'm going to press this button to apply the pulses. You can see a countdown in the console in the generator. And after that, 10, okay, we up to 6 atmospheres and maintain inflated until a sound is heard. Okay, down. You can see in the hemodynamics that the patient is doing some extra beats.
Okay, in DCG.
Let's see. Okay, let's do another run. These are the shock beats. The energy, the electrical energy of the shock wave is down. Is captured by the left ventricle, and sometimes you see some slight decreasing of the blood pressure, but always well tolerated, or almost always. But here, in this case, because of the limitation of flow, probably the patient has done some extra beats. Now we have to decide what to do to perform OCT, to post-dilate with a non-compliant balloon, or to treat the diagonal first. Let's do a cine probably. Contrast, please. And with the cine, we can decide. The first diagonal is a little bit different in the ostium, but the flow is okay. Why don't we pre-treat with a drug-eluting balloon the diagonal we have, and then protect the third one? We're going to pre-treat because we are trying to prevent putting a lot of metal in a small space, because probably the risk of thrombosis and restenosis is higher. So we are going to dilate with a drug-eluting balloon, a magic touch. That is a sirolimus eluting balloon. The second diagonal, that was the one we protected and predilated. And after that, we can try to cross a wire towards the third diagonal. Probably it is not going to be easy. And then post-dilate with a non-compliant balloon. Isabel is asking me about the heparin. As we are going through the radial approach, after the 31st minutes, we administer a little bit more of heparin. And if we continue after 1 hour, we check with the CT. This is a custom we have for the CTO procedures.
So in the OCT, now we are seeing the first diagonal. And as you can see, there is a lesion in the ostium.
Okay, just the ostium, no? So I'm going to enter here. Patrick, por favor, un test.
¿Cuál era el balón? Aquí,
6 atmospheres.
No, eso es.
So just here is a 2.0 balloon. Dale, 6. And you need to inflate it. The nominal pressure is 6. Okay, and just maintain 1 minute. You can see that this diagonal, the third one, have a very acute angulation there, and it's also at the point of the aneurysm. It's not going to be easy to cross it.
You see here in the OCT, the ostium of the third diagonal branch that is very angulated.
I'm going to change the curve. And if not, we can use a dual lumen microcatheter or just leave it without protection, because we have dilated with a shockwave balloon, and this diagonal is the same now. Probably the aneurysm hampers the crossing to the side branch, but also protect it to be occluded. I'm going to try with. I'm almost there, but the lesion is quite severe there. Okay, let's retrieve this one and give me the cyan black. And if not, we can debate the possibility of a dual lumen or just leave this branch.
Can we leave this branch, no?
Yes, because its behavior with the pre-dilatation, with the shock wave. Test, please. Yes, another option is to change the projection a little bit. We can try the right cranial. Angulation is terrible.
Yeah.
And also the aneurysm, because only with angulation probably you can manage reshaping the wire. So this is a dual lumen microcatheter. You can advance it as a rapid change through the wire we have in the LAD, and then trying to advance a second wire through the distal port. I'm going to change the shape of the distal tip of the wire, because it was done before the dual lumen microcatheter, and this, I think, is the last chance to cross to this diagonal that is remain. In mind is that the third diagonal is not a very big one. Test, please. Test is there, but I don't know if the wire can advance. Probably we need a wire with a little bit more power, and I don't know if it's reasonable to upgrade in this for this small diagonal. So we have the non-compliant balloon 3.0.
Yeah.
We need another balloon first for doing the trapping. We're going to retrieve the dual lumen microcatheter. If you have a wire you want to preserve inside, you need to do trapping. But now, as we haven't crossed through the side port, we are retrieving it as a rapid exchange balloon. And we are going to continue the procedure, dilating with an NC balloon. Let's check which wire is what. This is the one of the LAD. This is the one of the LAD. Okay. So you mark this one with the torque and continue with the NC balloon dilatation. It's a non-compliant balloon 3/15. You have seen the 3.0 balloon has crossed easily. Okay, this is the distal portion.
18.
Hopefully the third diagonal maintains open. The expansion is quite good down. It's important to see this expansion in orthogonal projections. Sometimes you have some surprises. Very good. I think it was the most tight lesion, the tightest lesion here. This is another portion.
20.
Very well expanded. Also here,
Yeah.
okay, down. And problem is the portion of the first diagonal that is not protected. But I think the osteum was almost free. Give me a test, please. Advance, wait a minute, just to be sure not entering in the left main. Test, please. Probably test. A little bit more distal. Test. Okay, there. Okay, up. Let's check how is everything. Also the side branches and the side stenting, no?
Yeah. Is the landing zone 3.3, no?
Test, please.
Yeah, the distal landing zone is 3.0.
I think all the side branches are there.
And the long?
The length of the stent is.
You think we can go with only one stent, or we need to overlap?
I think it's possible only one, no? Because
3.0 and then put
48 millimeters, more or less.
Do you think it's going to cross, or we are going to struggle?
I think it's possible to cross.
Yeah, maybe with 348.
We can try a 348. We're going to use trying to use a very long stent 3 by 48 according to the measurements of the OCT. Yeah, probably 48 is a good option. We have some space distal to this aneurysm to land if the lesion is a little bit shorter. But yeah, we want to land distally to this diagonal, third diagonal.
Yeah.
Probably 38 is not enough. You know, the first diagonal is a little bit. Let's continue. Test please here. Distally, I think is a good position, and we have to manage the proximal part. Test please. Have to advance a little bit more.
Yeah.
Test please. No. Okay, I crossed.
Yeah.
Know where I am. Test please.
Yeah.
Yes, perfect. Yeah, it's perfect.
You okay? Okay. Because if I retrieve a little bit, probably I get into the circ, so I think is the point.
I think it's okay, yes.
Okay, up. Now we were thinking about the length of the non-compliant balloon. We usually use the shorter one to do port proximally to the side branch, but this is a different bifurcation because we don't have enough space between the circ and the first diagonal, so we need to optimize the proximal part of the stent. We're going to use a 3.5 by 12, and if everything goes well, probably after that we can do an OCT and finish. I'm going to use the spider view for the proximal part. I think I'm there, okay? Blood pressure is okay, CG is okay. Let's retrieve the balloon. Test, please. All diagonals are there. So it's interesting to use OCT after the plaque modification technique to know if the result is fine. But if you want to save some contrast and you see a very good expansion in two orthogonal projections after NC balloons, after lithotripsy, probably you can skip this step and go to the distal, to the final OCT if we can cross it. You know, that is a usual thing with OCT that after the first or second use, the catheter is not so pushable, but slowly you can open the Y connector, and I think I'm there. Okay,
that's enough.
Okay, let's check if the guiding catheter is inside the vessel. Okay, I think I'm there. Let's work it here. I don't know if there is some issue with the catheter.
Okay, the alienation is good. So, go.
Injector.
Yeah.
No, something is wrong with the catheter. And the lens is broken because of this struggling in the advancing, and probably we need to open another one or trust in the angio.
Yes.
Let's check with the last cine we did.
We believe the angio.
I think the result is quite good. Obviously, the more proximal, the mid part of the stent is the worst part, but the area is quite good. The three side branches are patent, and I think it's a nice result. I think we're going to finish here and retrieve all the material. Thank you for your attention.